Today, you're about to hear from one of the most respected names in neurosurgery and pituitary medicine, someone who has not only advanced the field, but has changed thousands of lives in the process. I am joined by Dr. Nelson Oyesiku, professor and chair of neurological surgery and professor of medicine and endocrinology at the University of North Carolina at Chapel Hill. Now listen to this. Dr. Oyesiku is a leading expert in pituitary surgery and has performed over 4,000 pituitary tumor operations. Let that sink in for a moment. His journey started internationally. Medical degree in Nigeria, master's in London, PhD in neurosurgery at Emory, where he also completed his neurosurgical training. He's board certified, NIH funded, and his research is helping push forward the future of targeted therapies. And his leadership is global. He served as chairman of the American Board of Neurological Surgery, president of the Congress of Neurological Surgeons, president of the International Society of Pituitary Surgeons, and is currently president-elect of the World Federation of Neurological Surgeons. He's authored over 180 scientific publications and led some of the top journals in the field. Recognized as one of the best doctors in America, a top surgeon, and recipient of the Gentle Giant Award. So today, we're not just talking medicine, we're talking experience, precision decision-making, and what it really takes to change and save lives. Dr. Oyesiku, I am truly honored to have you join me today. Welcome to Talking Acromegaly with Tony.
Good morning. Good morning, Tony. Good morning to your audience and your show. It's been a wonderful introduction you have given me. I am honored and humbled by the graciousness of your words, and thank you very much. And I hope to have a nice conversation with you. And welcome. Thank you again.
The pleasure, Dr. Oyesiku, is all mine. Let's get into it. So, you've operated on one of the most delicate areas in the human body thousands of times. What goes through your mind the moment you're about to operate just milliliters away from the brain and all these crucial arteries that control someone's entire life?
I think the word is humble and careful, and understanding that anything can and sometimes can go awry, and you've got to be at your top of your game every time to avoid any errors of omission or commission. And every case is special. Just because you've done 4,000 cases doesn't mean your 4,001st case cannot have an issue that is different from the 3,999th case. And you've got to be prepared for any and every eventuality. The other thing that always courses through my mind is that every patient that comes to me in the clinic for a consultation or in the operating room for a surgical procedure is the brother, sister, son, daughter, father, mother, cousin, aunt of somebody out there, and is precious to them as their loved ones. And so I want to look after that person like I was sitting in that chair. And, it's not about me, it's about them and their families. So I think those are the things that I take into consideration every time we get into that operating room to do surgery.
Sounds good. I want to get into your approach. You were one of the first to use the 3D endoscopy in pituitary surgery, and one of the few surgeons in the US and worldwide to utilize the advanced 3D endoscopic surgery for removing pituitary tumors. Can you explain exactly what that is in that process?
Certainly. So when we do this operation, pituitary surgery, we do it deep inside in the brain, at the base of the brain, in a very dark area where there's really no ambient light, in the sinuses, the bone, and so forth. And it's about 9 centimeters or so from the tip of the nose to back where we are operating, 10 centimeters. So there's no light, no illumination. So you have to bring in illumination. And it's a small area. So magnification, making things slightly enlarged so you can see them. And these two properties, illumination and magnification, are essential for executing surgery in the pituitary region. If you go back in history, it started out where surgeons used endoscopy with the light sources, some without light sources, um, microscopes, and then down again to more recently into endoscopy. So it has undergone several cycles of evolution. The recent revolution or evolution in the use of endoscopy, the most recent began in the mid to late 90s. And at that time, surgeons were using what was called 2D, two-dimensional endoscopy, with light magnification, with a fisheye lens. And that allowed surgeons to see better because there was more light, there was more magnification. But as a result of the 2D lens and visualization, we were unable to have the benefit of what's called 3D or stereopsis, the ability to appreciate depth, shape, distance in the way we have evolved as humans to be able to do. And so that created some distortion. It's called a fisheye distortion. And so myself and a lot of other people, engineers and other surgeons, worked to put together a solution for this, which was the 3D endoscopy, which allowed us to use endoscopy, but also have the benefits of 3D stereopsis. In other words, the ability to see in 3D, which the microscope gave us. And so that's the story behind the 3D endoscopy.
You talked a little bit about history. I watched an interview that you did with the Dr. Edward Laws, and the two of you had an in-depth conversation that is far greater than I want to go into today. But you guys went way back in history, and
Mhm.
you talked about even during Egyptian times when they were performing pituitary surgery and got it pretty in depth. It's changed a whole lot since then, of course, but can you comment on a little bit of the conversation that you and Dr. Laws had about the Egyptian type of surgery and tell us a little bit about that?
Yes, of course. Well, you mentioned Dr. Ed Laws and talk about legends. He's a legend and a great mentor to myself and a great many other pituitary surgeons. And his contributions are probably unmatched. Anyway, we did in fact have a discussion about pituitary surgery and medicine, and that's online if you want to to peruse it as well. And we talked about the genesis of endoscopic surgery, microscopic surgery, but in particular, the role that the Egyptian surgeons played in this. And these were the morticians in Egypt, where they prepared the body for burial, but because they wanted to preserve it as long and as well as possible, they would remove the solid organs, the liver, the kidney, the spleen, and so on and so on. And then it would excerebrate, in other words, remove the brain from its cavity, the cranium. But they didn't want to do that by opening the face and opening the skull and disfiguring the face, because they wanted to preserve that for the afterlife. And so, as a result of their knowledge of anatomy, they figured out, like we figured out today, that the shortest distance from the nose to the base of the brain is through the sinuses, and that you could go into the sinuses through the nasal aperture on both sides, deep inside the brain, and open into the sinus without showing any signs on the surface. No incision, no disfigurement, no removal of anything. And the deceased could lie in a coffin and appear normal without any scratch on the surface. And so they were able to put probes and instruments, and we have those instruments in the museums. You can go and see them, where they have these probes and chisels and little tiny scalpels and suction tubes. They can remove the brain after they dissolve it in chemicals, so it will become liquefied like a jelly, and then they will suck it out. And that route going through the nose, the transnasal or endonasal, through the sinuses to the base of the brain, became the first time that we were able to do this procedure. And it was the ancient morticians in Egypt, thousands and thousands of years ago, that gave us that insight. And then in the early 1800s and so forth, surgeons in Europe resuscitated that methodology and were able to start applying endoscopy, which was only used at that time for hollow organs like the stomach and so forth. They started to apply endoscopy into the sinuses to be able to do surgery. Interesting.
That was something that was extremely interesting for me when I watched that video. Moving forward, let me ask you, what is something about pituitary surgery that even the most experienced neurosurgeons sometimes still underestimate?
Yeah, very, very good question. On the surface, people think that, oh, it's easy. You can go through the nares and to the sphenoid sinus, and in a matter of a few minutes, you can be looking at the base of the brain, and the tumor is just there, and you can go in and just remove it and scoop it out or suck it out and so forth. And there's a lot of misinformation in those sentences I just said. Yes, it's close by. It's not, it's, as I said, 10 centimeters with, or thereabouts here, they're 2.5 centimeters an inch. So we're talking about 4 inches deep. So yes, you can get to it, 4 inches deep inside. And yes, you can remove a little patch of bone and you could be looking at the tumor. But by goodness, everything I just said carries with it some potential risk. And I'm not talking about just a minor risk. You mentioned one earlier on, the carotid arteries. These are arteries that supply the brain with blood. There's another major artery called the basilar artery, which is just behind the pituitary, that supplies the brain and brainstem. And these are the major thoroughfares that carry blood to the brain. In close proximity are nerves that go to the eye that allow you to see. They're called the optic nerves. They're right just above the pituitary gland, millimeters away from it, not centimeters, millimeters. And then the brain itself, a vital part of the brain called the hypothalamus, which is about the size of my thumbnail. The hypothalamus controls all the vegetative functions of the brain: blood pressure, temperature, respiration, and so on and so on. And you can't live without a hypothalamus. Can't live without a pituitary gland either, unless you have hormonal supplementation. So you have these vital real estate that is just millimeters. My former chairman used to say it's a game of millimeters. Every little millimeter, off to the right, off to the left, going up, going down, carries with it potential hazard. And so you avoid that thought process at great risk.
I have such a huge respect for your craft. There's a lot of talk nowadays about mental health.
Mhm.
The amount of mental toughness and focus that it takes to be a neurosurgeon, in my opinion, is literally next level.
Mm-hmm.
What separates a good pituitary surgeon from a great one?
Yeah, I think it's the same thing that separates a great football player from a good one, or a great musician from a great one, is the application of talent, rehearsal, repetition, and you know, you've heard about the 10,000-hour rule,
Yes.
and that focus and that dedication to your craft, whether you're a jeweler or a horologist or a football player or what have you, that dedication to your craft to constantly improve and make better, and not accept that you are at the pinnacle, and realizing that there's always a nuance or something that can be done better. I think that's what separates the good from the great. And I think that applies to virtually every area of human endeavor, pituitary surgery, and whatever else you wish to talk about.
Is there a moment during the surgery when you know this is going to be a good outcome? I can tell right
Yeah.
now that this is going to be a good one.
Yes, absolutely. The classic one I would offer to you, since we're talking about pituitary surgery, is what's called a selective adenomectomy. And that term, that concept that I just alluded to, was coined by one of the great masters of pituitary surgery, a fellow by the name of Jules Hardy. He was a French Canadian and lived and practiced in Montreal. And he described the concept where a pituitary adenoma, which is a pituitary tumor, that is nested or sitting within the pituitary gland, is identified and found by the neurosurgeon. And there's a margin around that adenoma, like a perimeter, if you will. And around that, and then within that perimeter are the cells of the tumor that are causing whatever condition it is in the pituitary, say Cushing's disease or acromegaly. And the surgeon, realizing that perimeter, is able to enucleate, extricate, resect that tumor in toto, en bloc, completely, and remove that tumor, and only the tumor, preserving, relieving the normal gland, and separating the tumor from the patient, the disease tumor from the patient, and that results in a cure. And being able to execute that, you can actually see that in real time in an operation. And if you do that, and that comes to pass, almost invariably, that patient will be cured of that problem.
Wow.
So that's the one I would offer to you as the classic one in this area, at least.
As I mentioned to you a little bit about my story, I do have acromegaly, of course. From a surgeon's perspective, what makes acromegaly tumors unique compared with other pituitary tumors?
Mhm. Well, acromegaly is rare. That's number one. So it's much rarer than, say, a non-functional tumor. In other words, a tumor that has no hormone expression. So you're talking about a few cases per million, a handful of cases per million of population newly diagnosed, not a lot. So you mentioned at the very top of the hour that your endocrinologist was not someone who had seen. So can you imagine? And this is a specialist in endocrinology. So if a specialist in endocrinology hadn't seen one, well, how much less a patient who's a family physician or a general surgeon or what have you. So rarity, the rarity is one thing. And why is that important? Because the rarity translates to delays in diagnosis. Delays in diagnosis translates into reduced cure because the tumor has become more extensive or invasive and so forth. And that translates potentially to reduction in rates of cure, which means more likely that the patient may need surgery and other treatment modalities to result in control of disease or cure of disease. On the acromegaly side, in favor, on the positive note, on the acromegaly side, as distinct from some other tumors, is that there's the potential for treatment, say with medication, oral or injectable, or so forth, that we didn't have many decades ago, and we do have now. So making the potential for patients to receive other kinds of treatment where necessary. So that's you ask what are the distinctions in acromegaly compared with other pituitary tumors. So on a positive note,
Yes.
there's the potential for treatments. On the contrary note, the rarity, the propensity for acromegaly to invade, in other words, spread, leave the pituitary itself and get into areas around the pituitary, in the cavernous sinus, around the carotid artery, in the bone of the base of the skull bit. Those kinds of things are very common with patients with acromegaly.
You mentioned treatments.
Mm-hmm.
For patients, Dr. Oyesiku, who require repeat surgeries, what
Mm-hmm.
are the unique surgical challenges the second or maybe even third time around?
Sure. Well, I'll start with the first thing, familiarity, right? So let's say the first operation was performed by surgeon X, and the second operation is to be performed by surgeon Y. Well, what does surgeon Y rely on? The operative notes, the previous images, and so forth, but no direct knowledge themselves, right? Surgeon X, the first surgeon, has the ability, at least potentially, of recall, to understand and remember, oh, this is what patient had before. I read my operative note. I looked at my films. I recall this. So that knowledge is a major advantage for the first surgeon. So in general, for example, if a patient were to have a reoperation, all other things being equal, assuming the two surgeons are equal and they have the same skill set and experience, it makes more sense for the first surgeon than the second surgeon in general, just because of the kinds of things I mentioned. However, going in for a second surgery means that there's more fibrosis in the tumor, more scarring. The tissues around the dissection, the bone, have to be removed a little bit more sometimes. And the dissection, the separation of one tissue type or plane from another tissue type or plane is more difficult in a reoperation because you now have had healing by secondary intention, which means that there's more scarring. And scar doesn't separate as easily as virgin tissue. So that makes it difficult. And then you're almost always looking for a needle in a haystack. Usually the residual, the remainder or the recurrence is small or smaller than the original tumor, which was, when it was bigger. So looking for a smaller tumor, a residual that may be embedded in bone or embedded in scar or embedded in the sinus is a more difficult journey. And so those are the kinds of things that make a second operation more challenging, or a third operation even more challenging.
You've been around for decades, and you're a legend in your own right. What do young neurosurgeons today learn that you didn't learn in the beginning of your journey in neurosurgery?
Yes, I think in the years since I've trained and been in practice, compared with today's graduates, today's trainees, the kinds of things that they have access to are just amazing. For example, imaging. In other words, the ability to see inside the body without doing anything except putting the patient through an MRI scanner or a CT scanner or a PET scanner and so forth. That has improved by leaps and bounds. When I was finishing training, MRI imaging had just reached, the market. And so compare that to today, 3.5 decades later, I mean, MRIs are so sophisticated. They allow surgeons to see and plan better. So that's one thing. Another thing is something called navigation, surgical navigation. The best way I can describe that is like a GPS system. Imagine going to a city that you didn't know and you didn't have a GPS. You'd make a right turn and then, you'd figure out that it wasn't the right turn and you should have made a left turn and so forth and so on. Well, guess what? We have surgical tools today that in real time during the conduct of an operation can tell you where you should be making a right turn or making a left turn. That's a massive advantage. It used to be the surgeon relied only on their knowledge of anatomy, which, by the way, is very, very important because you've got to know your anatomy if you're going to be operating in this area or, in fact, any other area for that matter. But that notwithstanding, the ability to have navigation superimposed on the anatomical knowledge of a well-trained, experienced surgeon is a massive advantage today compared with, 35 years ago, 40 years ago. So I would offer those two as distinct advantages and differences, more importantly, for today's surgeon compared with last generation surgeon. And the future, is going to allow us to have better rehearsal, the ability to operate in virtual reality spaces that may make the actual execution of the the surgery in real time or prior to, even more effective and safe for patients.
You talk about the future of surgery. Do you think that AI would play a role in the future of surgery? Is that where you're going with that?
Yes, I do think so. I do think so. I think we're at the very dawn of the application of AI to the surgical theater. But like everything else, that technology is rapidly evolving, and there's no question but that we're going to see that. And for the current generation of surgeons, for sure.
Yeah, I want to be respectful of your time. I got just a few more questions. I know you mentioned that
Sure.
we're a little tight here. I just want to take a step back real quick. You mentioned kind of GPS and direction. Walk us through quickly
hmm
the moment the tumor comes into view. What's on your mind? What do you see? What are you thinking at that moment?
Well, the first thing I do is breathe a sigh of relief that we've got a chance today at making a big difference. And I always remind myself that this time, the first time, like as you described it, is the best time for this patient. There's no better day than today. We're never going to have the constellation of events and circumstances that we have today. A virgin case, a clearly defined tumor, one that's visible that we can identify. And then now it's almost as if we've been presented a platter of gold. Now we've got to convert. Now we've got to execute. Now we've got to make this happen. And so take a deep breath and then move forward to the execution. But reminding oneself that there's no better day than today in that circumstance where you have a clearly defined tumor and you can appreciate where it is and what it is. We've got a game plan.
Dr. Oyesiku, on that note, again, I want to be respectful for your time. I want to thank you for being here. I want to thank you for sharing the time with me that you have today. And most importantly, I want to thank you for talking acromegaly with Tony. It's been a pleasure today.
Tony, pleasure has always been mine. And as I said at the top of the hour, it's great to be here with your audience and yourself. And I'm humbled and grateful for the opportunity to comment and discuss with you today. Have a great weekend.
I'll close with this. Dr. Suku, again, I appreciate you breaking down the realities of pituitary surgery. You've dedicated your life to this work. The impact that you've made in the field and how it's changed lives of so many patients truly speaks for itself. For everyone watching, surgery is just one piece to the puzzle. If you want to hear from endocrinologists, click right here to watch a conversation with Dr. Otil Kargi. Or if you're wondering what it's like to live with acromegaly on a day-to-day basis, you can click right here where I share my story of being diagnosed with acromegaly.
Thanks, Tony.